Good evening, and welcome to Hernia Night in America, a twice-monthly destination to learn from top da Vinci inguinal hernia repair surgeons from around the country. Each surgeon presentation will align with primarily laparoscopic or open hernia surgeons and will focus on the impact that da Vinci hernia repair has had on their patients, their practice, and themselves. They will discuss their clinical and economic data, as well as their path to an efficient robotic hernia repair treatment algorithm. Please bookmark this site to register for future events and to see the schedule of surgeons as it becomes available. Tonight, Dr. TJ Swope will share his transition to making da Vinci robotic-assisted hernia repair his primary treatment modality. Dr. Swope is the director of the Center for Minimally Invasive Surgery at Mercy Medical Center in Baltimore, Maryland. He's completed approximately 600 da Vinci cases, and he's a regular contributor to both the International Hernia Collaboration and the Robotic Surgery Collaboration Facebook groups. He is also faculty for the upcoming second annual Global Symposium for Robotic-Assisted and Minimally Invasive Hernia Repair next month in New York City. We will have dedicated time for discussion at the end of his presentation. Thank you, Dr. Swope, for joining us this evening.
Hey, West Coast. What's up? Greetings from Baltimore, Maryland. My name's TJ Swope. I am sitting in my office at 9 o'clock at night in Baltimore, Maryland, talking to you West Coasters. Because I love robotics so much. Thanks. Thank you so much for that. So, hey, welcome everybody. Happy dinner time. I hope you're at a restaurant and hopefully getting a good meal. Listen to me babble here for a little while. So, my name's TJ Swope, and I am a general surgeon. I'm here in downtown Baltimore. I'm at Mercy Hospital. We are wedged right between Johns Hopkins, which I'm looking at right now out my window, and then University of Maryland about a half mile behind me the other way. We were interestingly, 2 years ago, got ranked number 2 behind Hopkins, ahead of Maryland, and the residents from Maryland come over here, and we're the kind of the cool teaching hospital for them. And so I got to welcome them from the number 3 to the number 2 hospital for about a year, but then they switched it around this year. So we're back to number 3, but it was a fun run. Anyway, my road to the robot, very convoluted to say the least. So I was a pretty proud robot basher, but it kind of was like a single site that drew me in initially, and someone said try the robot. I'm like, robot, it's kind of stupid, and who would really use a robot except a gynecologist? And I made fun of the robot extensively. I said, listen, I'm a good laparoscopic surgeon. I don't need a robot. Robot's too expensive. I mean, the turnover takes forever. I'm not too bad laparoscopically. I don't need a robot to do cases. That's ridiculous. So that was sort of my mantra, and I made fun of robotics and anyone that used the robot for a long time. And about 4.5 years later now, I have to completely eat crow. I would have laughed you out of my hospital 5 years ago if you said I'd be sitting here at 9 o'clock at night on a Thursday talking about robotic surgery. It would have been impossible. So I hate to say it, but I really like operating with a robot. It makes single site really easy, but I mean, for anything I'm suturing on, that's what I'm loving the robot for. Gastrectomies, colectomies, all my anastomoses, I do them intracorporeally now. Ventral and inguinal hernia, I can suture mesh in, and close peritoneum and close fascia. Hiatal hernias, same thing. I'm closing everything beautifully with the robot. Much easier to do laparoscopically. Again, I'm not telling you the robot's the be-all, end-all. Just think of it as another tool in your armamentarium of surgical power. So you have laparoscopy, you have open, and you've got robotic. And I think robotic's a very valuable tool. Again, yesterday I was doing a case, poor guy with Crohn's disease, multiple strictures. I had to do a short segment bowel resection and did 4 strictureplasties all on the robot. The guy, is tolerating clear today, and I'm hoping to be able to get out of here tomorrow. I mean, it's a very enabling tool. I really like it a lot. So, again, a couple of plugs before we start. First plug is for the Robotic Surgery Collaboration. I am an administrator on that. This is all things robotic in general surgery. Again, I was not a Facebook guy. That was not my scene at all. I didn't want anyone to get a hold of me. I didn't want to get a hold of anybody else. I was not into Facebook. But I kind of got sucked into it through the IHC originally, the International Hernia Collaboration. That's Brian Jacobs' site. This is Yusuf Kuzi's site. And this is a fantastic hernia learning source, and it's a Facebook group. There's constantly posting of cases and knowledge sharing on here, and also here as well. This is all things in general surgery. We do hernia, but we also cover, foregut, and colon, gallbladder, pancreas, and spleen. We covered all, adrenal on here as well. So if you're not on Facebook now, I would join, and if you do nothing else, just join in for this one and this one, and it's going to be better than all of the last 5 years of meetings put together. That's my plug. So again, what's going on with the Da Vinci and hernia? Well, there's actually been a pretty significant increase in the volume. You can see open surgery sort of drop off here pretty quickly, and laparoscopy starting to drop off as the robot's kicking into gear. So a lot of people are kind of jumping on the robotic bandwagon because it's super enabling, and it lets you do cases that you really couldn't do as well laparoscopically. You can now do robotically, and I think that's really true for ventral hernia. But also, I think it's nice for inguinal hernia as well, and that was an unexpected finding for me, which I'll talk about in a minute. So here's the adoption in a different way of looking at it. Look at the comparison of 2012 to 2016. The robot is really taking off in ventral hernia nationally. And again, all the big wigs, you got Mike Rosen, Yuri Nowitzki, all the big players are getting on the robot now for their hernias, and it's a nice tool. Another reason to consider an MIS approach, if you're an open guy, is that the reimbursements went up significantly for a hernia from an MIS approach versus doing it from an open approach. So starting out, so you're new to robotics, you're thinking about getting robotics. What's my mantra? My mantra is you want to get good. Click there. You want to get good, you want to get fast, and then you want to get cheap. So how do you get good? Well, to get good, you have to do cases. So you don't want to decide to do a case once a month and then think you're going to be a pretty good robotic surgeon. That's a pipe dream. Like anything, you have to be good with it. So I think you should get on the robot and get on the system, get comfortable with it. I started doing easy cases. I started doing gallbladders in the beginning. And then eventually I started jumping into more difficult cases, and you'll be surprised. Your learning curve goes very quickly with the robot, especially versus laparoscopy. Again, as you're getting faster and better, guess who else is getting better? Your team's getting faster. Your turnover is going to get faster. They're going to kind of learn the ins and outs of robotics if that's new to them. And as a team, you get better and better. So I think having a consistent team is very important as well. Again, you want to get fast. As you do more cases, as you get good, you're going to get faster. And the faster you go, the faster your team goes, and the more cases you get done, and the more cost effective the robot becomes. Again, you need to let your administration know in the beginning, though, that before you get good, you're going to be slow and expensive. You're going to do fewer cases. You're going to be slower until you get past that learning curve. Then once you get the kind of up the hill, then you get over your learning curve, then you start getting really fast. And that's when you get down to here, when you can get cheap. I've started cutting out instruments. I streamlined Medline packs, all kinds of things that cut costs, and I've become very cost efficient at robotic surgery. So tonight we're going to talk about inguinal hernia repair on the robot, which is something that I really did not expect to find myself enjoying or wanting to do. It's really the last thing I actually adopted, and it was kind of a surprise. And I kind of got talked into it by Jason Hart, who works at Intuitive. He's like, just give it a shot. I'm like, Jason, I don't know, dude. And he's like, just try it. I'm like, I'm a really pretty happy lap tapper. I don't really need to do the robot for that. And then I tried it, and I was surprised I ended up liking it, and actually liking it a lot. So inguinal hernia-wise, here's what the penetration is now. It kind of stalled at about 20% or so. And the reason it's stalled is that it's a hard operation to do a laparoscopic TEP. It's difficult. A lot of guys have a difficult time learning it. It's got a long learning curve, and it sort of pushes people away from doing an MIS approach. So most hernias now are done in an open fashion. I think the robotic TAP, especially if you're an open surgeon, it makes the MIS approach more obtainable, faster, and in an easier fashion. So generally, as I'm cruising around the country talking, there's two groups I generally run into. The first group is the guys that are open guys and thinking, why would I consider a robot for a hernia repair? And then there's the guys that were like me, a laparoscopic TEP guy. Like, hey, I'm a pretty good lap TEP guy. I don't need a freaking robot to do an inguinal hernia. That's stupid. So, why would I even consider switching? And that's exactly what I used to say. So I'll start out with the open guys. If you're an open surgeon, hey, why would I consider changing to a minimally invasive approach? And that's a legitimate question. So let's start out looking at recurrence rates. So if you look recently, the Archives of Surgery 2012, this is a well-conducted 250-person randomized prospective trial looking at TEP versus Liechtenstein. And again, these people that were doing both these cases, the TEPs and the open cases, were people that were experienced. This is not the VA study where you had interns and residents operating on these people that weren't past their learning curve. These people were all past their learning curves on both sides. And when they compared them, the recurrence rates for TEP was less than 1%, and it was over 4% for the open approach. Again, here's just another study. I like the volume on this one. It's well over 1,000 people getting a TAP approach, and the recurrence rate in this study was 1.7% for the TAP approach and 2.3% for recurrent hernia. So very low recurrence rates for the TAP. Again, the nice thing about a minimally invasive approach, the MIS approach, the preperitoneal approach, is I get to see the other side every time. Well, if you're an open guy, you say, so what? I checked the other side in the office and I didn't feel anything over there, so I'm just going to fix this one side. Well, the problem with that is that about 25% of the time, there's a hernia on the other side that you did not appreciate on physical exam. On a clinically negative groin exam, 25% of the time there's an inguinal hernia, and that's from Urinovitzky and Bittner. So again, that's a significant number of people that are not getting their hernia repaired when they should get it repaired. So another thing with open inguinal hernia repair is I don't really look for femoral hernias unless I know there's a femoral hernia and I'm going there to operate on it, right? Someone comes in with an incarcerated femoral hernia, you do an open, well, you're going to see their hernia. But like most people don't, dig down through the transversalis fascia, check the femoral canal in everybody. But the cool thing about the MIS approach is you get to see that every case. Again, they're very easily identified, these femoral hernias, with an MIS approach. And you're just not going to see that open. So can you go to the video here? So here we go. And here we go. So here is a, come back. So here's a femoral hernia, again, that I probably would have missed if I'd done that case open. Is that a big deal? Probably not. But again, as that patient ages and they start losing their fat and getting thinner, that then becomes an open hernia. And then that's the little old lady that came in that you had to fix her incarcerated hernia on. So again, not a huge deal, but you see them every time, and you don't see that with an open approach. The other great thing about this approach is you're going to see the entire myopectineal orifice. There's the lateral border of the rectus sheath, there's your infraepigastric vessels, and that's your inguinal ligament, so that's going to be Hesselbeck's triangle. Lateral to the epigastrics is the internal ring here. Your space of Retzius gets opened up, so this entire orifice, the myopectineal orifice, can get seen and then covered with mesh. Let me go back to the slideshow, please. Thanks. So again, let's look at postoperative pain, open versus MIS. So this is out of the Archives, 2012 again, and they looked at postoperative pain in the short term and the long term at 5 years. And so I think these numbers are significantly higher than my experience, but in the short term, they saw significant pain in 32 of open and 23% of MIS, and at 5 years they saw 28% and 15% of patients open versus MIS. And over here, this is a standout for me, is this one here. Again, folks that do open hernia repair, a lot of those guys will literally take the ilioinguinal nerve on purpose so they don't get nerve entrapment by the mesh. And then the problem with that is that a good number of those people end up with a numb spot in their groin or down in their mons pubis there, and again, it's a significant number. Almost 1 in 5 people are going to get that numb spot versus almost no one gets that with an MIS approach. Again, I don't be walking around with a numb spot in my groin if I don't have to. So, and you get to avoid that with the MIS approach pretty nicely. Again, here's another one looking at chronic pain after open versus MIS, and they saw an 18% incidence of pain after open and 6% after MIS approach. And they defined chronic pain as lasting greater than 3 months. Again, here's another one, a randomized study, and they're looking at patient satisfaction and pain levels in MIS versus open approaches. And again, here is, look at the pain scores here, and at the higher end of the pain scores, most of the MIS patients are here on post-op day 1, and most of the open patients are here on post-op day 1. When they look at the overall satisfaction of MIS versus open, again, at 1 month and 3 month, the satisfaction rate for the MIS approach was higher. So that's me beating up on open hernias, which I still do in folks that I can't put to sleep under general anesthesia and do a robotic approach, and I have to do them open under sedation. I will do those folks open. Otherwise, I am all on the robot, all MIS. So again, like me, I was a laparoscopic TEP guy. And I'd done well over 1,000 TEPs, great operation, did a lot of them, and really liked it. Why would I consider doing a robotic TAP? So again, the advantage of the robotic TAP, well, if you're an open guy, it's certainly much easier to learn a robotic TAP than a laparoscopic TAP. That's just self-evident, having done both. It's pretty obvious. Again, with the robotic TAP, I can very easily identify all the anatomy because I make this huge pocket. And I end up putting in a large piece of mesh now. I used to use a large piece of mesh routinely on my laparoscopic TAPs, and doing the robotic TAPs, I use 3D Max. Doing the robotic TAPs now, I pretty much use an extra large piece of mesh unless it's a relatively small person. I'm getting a much bigger pocket and getting a much better coverage of the whole MPO now doing a robotic TAP versus when I did a laparoscopic TAP. Again, I get to see both groins immediately. I don't have to dissect out the other side. I can look right over there and see it. Again, my dig on the laparoscopic TAP, and if you're a laparoscopic TAP person, it's not my thing. I would do a laparoscopic TAP when the residents would tear the peritoneum and it's a big mess and have to convert from a TEP to a TAP. What I didn't like about it was the closure of the peritoneum. I would tack the peritoneum back up, and it just never looked good, and those tacks obviously hurt more, and I was just never super satisfied with the peritoneal closure on a laparoscopic TAP. But with the robot, you get this really nice closure of the peritoneum with the 2OV lock, and it's very durable. I've had to go back in on people, and it looks great. Not for the hernia repair, but for unrelated reasons. And the peritoneum looks really good. So my concern over the peritoneum breaking down with the tacking and looking crappy has gone away with the use of the V-lock on the peritoneum. I really like that. It looks really good, and it holds nicely. Again, if you're doing a TAP, you don't really know where the bowel is. You don't know where the bladder is. With the TAP, I think you get a better feel for that. You can see where the bowel is exactly. Again, on the TAP, the patient's had diverticulitis, the colon's plastered right against the peritoneum. You're peeling things back, you're boving, and you can get a thermal injury there, whereas I know exactly where the bowel is when I do the TAP approach. Again, the other cool thing with the TAP, and I guess I could have done this laparoscopically, but I didn't. I sort of learned to do this robotically, is that what does everyone get with the big direct defect postoperatively? In my experience, they all got seroma. So big bilateral TEP hernia repair, laparoscopic TEP, and they all come in with golf balls in their groins. And they go away eventually, but I mean, no one wants to have a golf ball if you don't have to. So I can take care of that robotically now. So you can play the video. So here you're going to see me coming in. I'm going to take bites of the pseudosac, the transversalis fascia here. I'm going to tack that down to Cooper's ligament. I'm essentially going to close this dead space. Again, I like to tack it down here. Other guys will tack it out that way or tack it up. But the point is to take that and close the dead space. And then by tacking that transversalis fascia down, I not only close the dead space, but look what I'm doing. I'm creating surface area here for my mesh to adhere to and really close that space down. So it allows for easier, quicker incorporation of my mesh here. And it closes that dead space down. And I think I take another bite here to tack it down some more. But that closes that space down. And again, I just don't see seromas in these big directs anymore. You can go on to the next slide, please. Again, TEP versus TAP. When you talk about length of stay, when you talk about recurrence rates, when you talk about acute and chronic pain, it's all the same. TEP and TAP are pretty much equivalent operations in terms of those things. Whether it's the Cochrane review or this is a big study, over 4,000 patients there by gas. I like the volume on this one. Again, the Cochrane review is a pretty similar thing. Chronic pain, acute pain, recurrence rates, all the same, TEP versus TAP. Pretty low. So both equivalent operations that way. Pain afterwards, again, chronic pain rates, 0.6 and 0.7 over almost 2,000 patients, TEP versus TAP. Pretty equivalent, very low. And that pretty much says the same thing there. So the bottom line with MIS is I think there's no significant difference in recurrence or pain with TAP versus TEP. I think they're basically equivalent. TAP, I think, is easier to learn and perform than a TEP, in my opinion. And I think versus open repair, there's less pain and lower recurrence rates based on the data I showed you. The problem is it's the robot, so it's got to be way more expensive. So I started digging into this with my administrators, and this is what I initially came up with, and this is patently false. This is not my average cost at all. So I don't know if anyone out there has tried to dig down on cost with your administration, but it's frightening what you find out when you start doing that and what they really don't know. So you have to really start digging in, dig your heels in, and eventually once they realize you're on the same page and trying to save them money, they're very forthcoming with cost and data with me, which I was pretty surprised at because I'm saving them a lot of money. So again, this is what I thought my data was, but it turns out, I'm grabbing the wrong one. There we go. So, but this is actually my data. So what I thought was my cost in history, that was simply my supply cost. And then when I look at the reposables, I use 3 instruments. I use a hook, a ProGrasp, and a suture cut. And those 3 instruments are $640. It costs about $150 to process the laparoscopic tray. And when you turn to maintenance cost, here's the maintenance cost. So everyone says, hey, TJ, there's a maintenance cost associated with a robot. And so you know what? You're absolutely right. But let's break that down. So we have 2 robots. It's $330,000 a year divided by number of cases. And for us, it comes out to about $316. That's actually gone down as I got into robotics because the more cases I do, the lower that number gets. And it's actually probably a little bit lower than that. Our maintenance cost, actually, since I've gone more on this and down on this cost has gone up a little bit. This cost is now $278. Again, we're an Olympus facility, so Olympus covers our GI scopes and all of our laparoscopic stuff. So on contract with them, it's like 500 grand or something. But you take out the GI scopes, and you leave the remaining money, divide that by the number of laparoscopic cases we do, and that should be the laparoscopic maintenance cost, and it's almost a wash. It's a little less expensive, right? But it's almost a wash. And so this is actually $278. So you can drop this up another 21 bucks, drop that down 21 bucks. Is it fantastic or less expensive on the robot? No. But again, it's not fantastically more expensive. It's equivalent or a little less expensive robotically. Again, this is the cost margin model. Again, I'm not breaking out the Absorbitech and the balloon dissector, and that's where a lot of my costs went into for laparoscopic. Again, this is laparoscopic me versus robotic me. I can't compare me to you. Your contracts are different. I'm just saying cost margin model. This is it. This does not include the cost of the robot amortized over so many years and covering the cost of loss of, what the hell is I'm looking for? Anyway, inflation and the cost of thing, depreciation, thank you. So depreciation cost and the amortization of that spread out. That comes out of the capital budget. That's an entirely different cost thing. This is what people are going by cost margin when you talk to people about how much does your case cost. You sit down with your CFO. This is what they're into. This is the number they go by. Again, how long does a robotic tap take? Well, it's certainly I'm getting quicker and quicker. So I was pretty slow my first 5 cases. I mean, it was taking me on the console like an hour or so. Now I'm quicker. I'm even quicker than this now. Probably for bilateral, I'm really now running about anywhere from 22 to 25 minutes per side on the console. Again, thrown in here is big scrotal hernias. Those are cases I used to do open. Now they take me longer to do on the robot. I may be, an hour, on a side to do a big scrotal hernia versus doing it in 20 minutes. But again, my patients are getting the advantage of an MIS approach, but it is going to drive up my average time on those cases that I was doing open before. Total procedure time, I'm now down, this is less than that. I'm probably down around 70, 75 minutes or so for a bilateral inguinal hernia repair, skin to skin. Guys are faster than me. God bless them. That's how long it takes me. Again, I'm now doing big scrotal hernias, which I didn't used to do before, and I'll talk about that in a minute. Unilateral now, I'm about 25 minutes or so on average on the console on a unilateral hernia, and they're taking me now about 45 minutes or so. Here's the setup. So this is the setup on the SI. I put my camera in here at the umbilicus. I like to go just above the umbilicus rather than going just below the umbilicus, and cosmetically it doesn't really make much of a difference. So why would I consider that important to do that? Well, again, you're going to be closing the peritoneum, right? I do tend to preserve the umbilical folds, but I close it right to here, right? And then I'll close it starting from here and going over. And it's a difference between right here and sewing right in front of yourself versus being a little further away and able to sew. So even 2 or 3 centimeters when you're sewing up close like that makes a big difference when you go to close the peritoneum. So I like to go just above with the camera, and then I usually go above that. This is probably a little bit higher. I'm more close to the actual numbers on my port sites here, more like here, because if I go up here, the camera and the number 1 port are going to be banging into each other. So I come lower so that angle's offset a little bit, and same here. And this is what the setup actually looks like. Again, I like a 12 millimeter balloon tip trocar for this. You can use a smaller trocar. For me, the 3D Max, which is what I use, when I stuff that through a smaller trocar, it kind of loses its shape and it fractures a little bit around the edge, and I just don't like the way it looks. So I like to slide it down to 12 trocar because that preserves the shape of the mesh. I like to use a balloon tip trocar specifically because I'm going to ask Mackenzie, my PA, to back it up. She works with me. Mackenzie rules. I asked Mackenzie to back up the trocar. Say I'm suturing the peritoneum here. I can say, Mackenzie, back the trocar, and she'll burp it back and pull the trocar back a little bit, maybe a couple centimeters. And that's really all I need to give me enough space to roll medially there if I ended up a little bit high with my peritoneal opening. And the difference is when I first asked her to do it, when I wasn't using a balloon tip trocar, I asked her to back it out, and I was looking at the outside of the abdominal wall. And now I'm looking at at least 5 or 7 minutes or so to get the trocar back in, clean the camera, reestablish pneumoperitoneum peritoneum, and that's a big pain that took us. With the balloon there, it'll never pull out, and you're never going to have that unpleasant experience. So take my advice and do that. And same on your ventral hernias on the SI as well. Same thing can happen. So here's how I dock, and here's my setup. So I like to parallel dock. I keep the robot right here in the corner. The head of the patient's here, and I literally run the robot right in sideways, right up parallel to the patient. I take that middle grade boom, the camera boom, and I line it up just at or above the knee of the patient. At or above the knee seems to be the perfect spot. And then I throw the camera, I line up the camera, dock that, and I dock these guys. I throw the elbows out like you would do for single site. I elbow out these 2 guys and dock them and rock and roll. Again, this is my setup for a left inguinal hernia. And this is my setup for a right inguinal hernia. And this is my setup for a bilateral inguinal hernia, right? My setup's always the same, super fast. You can come in at a 3rd-degree angle if you want. I know guys do that. You can put the patient in lithotomy and go through the legs, but I'm not a gynecologist, so I do it this way. Again, here's the anatomy. If you're an open guy, you're not used to seeing it from the inside, from an MIS approach. Again, this will be your inferior epigastric vessels here. So medial to that will be your triangle, your hexaback triangle. So your rectus muscle is going to come in over here, inguinal ligament coming across here, and epigastric, that makes your triangle. Lateral to that's the internal ring. So here's the cord structures coming up, and the vas deferens coming up to join that at the internal ring. Medial umbilical fold here, Cooper's ligament, right pubic ramus, bladder. And here's a triangle here. That's called the triangle of doom, and that's where your iliac vessels run. You don't want to make holes in those vessels. That's not good. And out here is a triangle of pain. Inguinal ligament running across here, the cord structures here, and that triangle of pain is where the nerves are. So lateral femorocutaneous nerve runs up that way, the femoral branch of genitofemoral runs up that way, and you don't want to injure those nerves because you get people chronic pain afterwards, and they will not like you very much. So this is from the International Hernia Collaboration. A shout out to Brian Jacob. This is off of the Facebook site, and we're calling this on the International Hernia Collaboration. We call this the critical view of the myopectineal orifice. I'm going to call it MPO because I'm tired of saying that. So here's the critical view of the MPO. Again, really important is to get that peritoneal reflection down. I like to see a nice triangle between my cord structures and my vas deferens and have that peritoneum down. If you don't have the peritoneum down far enough, what will happen is your mesh is sitting here, and then the peritoneum's going to, the space will uninflate, basically, it'll deflate, and then that bottom peritoneum, the bottom mesh edge will flip up, and you're going to clamshell and get a recurrence. I think that's probably the most common cause of recurrence, in my opinion. Pubic tubercle, left pubic ramus here, space of Retzius is opened up here, the triangle is here, your femoral canal here, all this is exposed. Reduce all cord lipomas. They can be a lead point for recurrence, and if you don't reduce it and you put mesh up there, they're still going to feel that lump and think you didn't fix their hernia. So please reduce all those lipomas. And that's the critical view of the MPO. Again, this is what the mesh looks like. This must be a large. I sort of switched to the extra large. My mesh now in this situation will come out over here, kind of down over here and up this way. I use the extra large almost all the time now. And I used to use the large routinely. So this is how we get started. On the left side at first, I asked Mackenzie, hey, Mackenzie, please push on the anterior superior iliac spine. You can see her doing that here. And then once she pushes on the ASIS, that's my mark, and then I'll just start doing my preperitoneal dissection going across. Same thing on the right side here. I'd say, hey, Mackenzie, push on the ASIS, and she does that, and I start right at or above that, and I start my preperitoneal dissection over here, and I come across. Again, the rub is, if you go too low here, right, what's going to happen? It's a quicker dissection, but then when you put the mesh in, the mesh is going to be sticking in above, in front of this peritoneum, so you have to kind of sort of reach underneath and undermine that superior flap to get to come around to go over the mesh. If you go too high, what happens is it's a longer dissection, and then when you go to sew the peritoneum closed, it's like right in front of your face, and it's super torture. So just at or above the ASIS seems to be just about the right spot, the ASIS. Next slide, please. So here we go. I think we have a bilateral hernia repair here. And this will drag on for a little bit, but you can start this one. That'd be great. So again, I'll have Mackenzie push on the ASIS, and there we go. And she's pushing it, and that's my sweet spot. That's where I start. So now I'm just going to come across with my hook, and I'll go into the preperitoneal space. Again, that's a transversalis fascia here. Again, you can go pre-transversalis fascia if you want to. It just puts you right on the vessels and the muscle. It's a more vascular dissection, lots of little perforators. You have to zap all those things. So I like the preperitoneal plane personally. As we come on down here, you can see the inferior epigastric vessels here. You can start to expose the symphysis pubis and the right pubic ramus here. The triangle is right here. Epigastric vessels, inguinal ligament, and lateral border of the rectus muscle. So that's the direct space there. It's probably a little direct there. And lateral to that's the internal ring. Again, pubic tubercle, space of Retzius being developed here. Not going into the triangle of doom and causing life-threatening exsanguination. Internal ring. Again, a lot of the lap teppers out there are blunt. Don't use any cautery guys. So if you're a blunt, don't use cautery guy. I would turn away at every one of my videos because I'm going to be using a lot of cautery. So I don't get nerve injuries. I know where they run. I'm very careful. And I don't like red stuff that's going to ooze and then give a hematoma afterwards. So here's my sac in here. I'm going to free that off my cord structures. I will make a little hole in the peritoneum here, which I just fixed a little Vicro later. I don't make too many holes, but not a big deal to make a hole. It's easy to fix. And I really like to expose this space and make a lot of room for my mesh. There's the vas deferens there. And ultimately, you're going to see that nice little triangle I talked about with the vas coming up this way and the cord structures running this way. And getting that peritoneum way down here to allow my mesh to sit across this without flipping up when I deflate that space. Again, making more space here for my mesh. And here I am getting started on the other side. Again, preperitoneally, coming across. Again, the great part about this versus a TEP is you're at the mercy of the balloon. You could be preperitoneal, you could be pre-transversalis fascia. You don't know where you are half the time. And when you get those bloody dissections, that's because you end up with the balloon in the pre-transversalis fascia space. So there's my sac, indirect sac. When you get that reduced, preserve my cord structures here. Again, plentosectors look away, lots of cautery here. And we'll get that reduced nicely. And once I get my sac down, I get everything dissected out. There's my sympus pubis, my space of Retzius. There's my triangle here. And again, I can see things so well. The view is great. I know there's 3D out there on the Olympus with the glasses and stuff. This is a large 3D mesh. But with the Olympus, you're kind of your glasses on, you're looking through a little 3D window across the room. But versus the robot, it's a 3D immersive experience. Your head's inside the belly and you're looking around like you're sticking your head inside and looking. It's a much better experience for me. I see things in much better detail. I think the 3D here is really tough to beat. Yeah, for me, what I like to do, I like to secure the mesh in a couple places. I stitch it to Cooper's, and I like to place a stitch out here superlaterally just to keep that mesh from sort of shifting and getting that lateral underneath recurrence. This is just what I do. Some guys glue it. Some guys just do nothing and just throw it there. Some guys like Pro Grip. We're barred, so I like the 3D Max. Again, I've gone using the extra large piece pretty much routinely now because I can create such a lovely pocket with the tap approach. I was using a large piece before, and it was difficult to get that extra large with that tap approach. Where these guys crisscross in the middle, I'll suture them together there and essentially end up with a Reeve Stopa here with mesh just covering the entire lower abdominal wall. Again, I get recurrences, everybody get recurrences, but I really think I'm doing a pretty good job here. And the ring's covered, femoral canal is covered, the floor is covered, down to the space of Retzius, everything's covered, and then I go ahead. Again, I never loved the peritoneal closure doing a tap laparoscopically because I would tack it closed and it just didn't look good. Again, this is a very secure closure of the peritoneum with this V-lock. It follows itself, and I've gone back. I had to do a colectomy on a guy about 6 weeks after an inguinal hernia repair because he was super symptomatic from the inguinal hernia. Want that done first, and I looked back, and the peritoneum was beautiful, clean, no adhesions. And everything was peritonealized. That V-lock suture completely peritonealized. Again, this is just going. Again, it goes very quickly. You get very quick at this. And again, tend not to pull down. You'll tear the peritoneum more that way. Kind of pull parallel to it when you're pulling on it. And that's what it looks like after I've done it. And I'll just whip stitch that closed with a little 36-cent tool Vicryl and get out of Dodge. There we go. Next slide, please. So that's a bilateral repair. So scrotal hernias. For me, that was an open approach before. I would try doing them TEP, and the problem I would usually run into, especially with a big scrotal sac, is I would just sort of give up on the scrotal sac. I would never get it out completely. I'd end up dividing it. I'd endoloop it proximally and leave a mesothelial sac in the scrotum, which would then fill with fluid and last forever. Or I'd have to go back and excise it. So I was never a huge fan of leaving the distal sac. The nice thing about the robot is I don't have to do that anymore. I always get the sac out. I've had the testicle up in the field and thrown it back down. I always get the entire sac out. Again, so a practice change for me as a lap tepper, I would do an open approach for large scrotal hernias. I would do an open approach for previous prostatectomy. I would do an open approach for previous GYN surgery. And those cases are all now having the advantage of an MIS approach because I can very comfortably get them done on the robot. And I was, initially a little nervous about the prostatectomies, but those have been not a big deal. I've done very well with them. I don't have the video. It's on the Robotic Surgery Collaboration or the IHC. If you look under my name, it's on there somewhere. But I did someone that had a previous open repair, previous prostatectomy, and previous penile implant. And I did that one robotically and went fine. So challenging case, but I was able to get done with the robot very nicely. So again, practice change for me as a lap tep guy. All these guys that were open now get the advantage of an MIS approach. So these are the kind of hernias I'm doing now. On the left here, you're going to see just a hint of mentum. I think we skipped a little bit there. Let's go back to that one. You're going to see a little bit of momentum coming out on that left side there. There we go. Again, the side had about a good solid softball to small grapefruit scrotum. But I'm going to get all this stuff pulled out, all this momentum. Notice my sutures are in there already. My mesh is already in there. You don't see it, but it's in there. So there's that left-sided defect. Again, that was an open approach for me before. On the right side here, you're going to see another hernia that I took care of with the robot. Again, this gentleman presented with a large scrotal hernia and just a hint of small bowel in his scrotum. And then like 3 or 4 feet of small bowel down there. Again, fix this guy. This gentleman had no seroma postoperatively and a huge sac. This guy over here, he ended up with about a 7 centimeter seroma or so, but he had an enormous hernia. So we'll see this guy's repair here on the next slide. So you can jump to the next slide for me and play that. Oh, I can advance it. Can you play it for me? Well, if you can imagine a big indirect defect here and then me pulling peritoneum out, that's great. Was it playing on yours? Mine went dead. So I'm going to now look at someone else's laptop. So again, if you look, okay, am I coming back? All right, I'll jump to you. So again, if you look to, can I do it with you? Oh, good. So here is the canal, and let's see, I break out a progress, and I like a bipolar here. And I was not a huge fan of bipolar energy in general, but I've really grown to appreciate it, especially on cases like this. Here I can pull the cremasterix and the transversalis fascia off of the sac, and you see me peeling the transversalis off here. And then if it's oozy or bloody at all, then I'll just grab it and I bipolar it. I'm going to bleed a little bit right there. I bipolar it, and then I can reduce that, and it sucks back down to the scrotum, and it's nice and dry. So you see, once I get this monstrous windsock of a sac out of here, there's still more. We'll take a look down the scrotum. You see it's nice and dry down there. So I'll break back to the hook to finish up the cremasterix here, and then I'll finish off the sac. Now, I've edited this video. I did edit this, so I know I'm going to get that sac fully reduced. Just wait for it. Wait for it. There it is. All right, so we got it totally reduced, and look at that. So bone dry, huge scrotal space, but bone dry. So you got a little bit of a seroma up here, but that scrotum was flat and soft and dry, no seroma. Then I just throw my mesh in. And we can cruise on to the next slide. They don't have to watch me secure mesh anymore. They've seen enough of that. Oh, all right. Switching back to my computer. I had to do a computer switch there. Back to mine. So next slide. I love a surprise. Who doesn't love a surprise? So I'm doing a robotic tap on a gentleman that had a previous open left inguinal hernia. And I pop in, and sure enough, he's got mesh in the preperitoneal space. So can we go to that video? Play that for me. So here we go. So here I do break out a scissor because this is a pretty delicate dissection. And again, you can do this laparoscopically, but it's certainly, I think, for me, harder to do it laparoscopically. Although I've done it laparoscopically, it seems easier with the robot because I can see those planes so much better, and such better control. Anyway, so there's the epigastric vessels here. And here I am just working the sac, working the peritoneum off of the scar and the abdominal wall. In this case, I left the peritoneum and the mesh as one and use that as my peritoneal flap. You can also get the peritoneum off the mesh and then remove the mesh, but for me, it's just easier to leave the mesh. And again, that was the direct space you saw, direct defect. Here's your epigastric vessels right here. So I'm going to slowly, very carefully work the epigastric vessels off the mesh. And this actually goes pretty nicely. The case overall, it took me, I think it was an hour and 10 minutes. I had a visitor from California for this case. I still remember that, my only California visitor. So shout out to you folks in California. But here I'm going to slowly work it off of here, get my mesh freed off, and then I'll go and attack the direct defect here in just a second. And here we go. So there's the vas deferens running up in the canal right there. You can see that. I'm going to divide this stuff here and then really expose this whole space and get back and free up my cord structures a little more. If I get it all reduced out of there. Again, this guy's had previously placed preperitoneal mesh. I'm going to do the same thing, spacer retius, get it all opened up. Here's the epigastrics. You can see them pulsating, and we're just going to free them off the mesh here very nicely with the scissors, very gently. As I get closer down here towards the iliacs, I'm going to kind of move away from the cautery a little bit and do a little more blunt dissection, just so I don't make a hole in anything really important. But again, I'm leaving my mesh here and my peritoneum as my flap. And then eventually I'll get that freed off. Go a little lower. You're starting to see my cord structures here. There's vas and cord structures over here. Iliacs are right here, so I'm very bluntly dissecting the mesh off of the iliac vessels. As I get off the vessels out here, I'll break a little cautery back out and get that freed up. And once I finally get that all freed up and reduced, I have enough space for my mesh, then I throw my mesh in. So here's my internal ring, that's enlarged. Here's my cord structures. Here's my vas deferens. There's my direct defect over there. And so I'm going to throw in my mesh and get out of Dodge. Again, this guy went home. His pain score at 2 weeks was 0, and a very happy guy. So I think I'll end up throwing a bunch of extra stitches beside my usual 2 in him. So I didn't want this mesh to move because of the direct defect, so I anchored it here. I'm going to anchor it here in just a second. I put some up here in the middle because I don't like my mesh to wrinkle or fold at all. So I'll throw a bunch of extra sutures in this guy just for peace of mind. Anchor it there immediately. This is my 36-cent 2 Velcro. I love that. Do another one there. I don't know where that is, but I threw one there. Oh, it's probably at the ring. I probably anchored it right at the ring. Put one super lateral just so I don't shift up and get that lateral recurrence. I want that to sit nicely, and I threw another one here so it just laid nice and flat. And boom, there it is. And this patient did very, very well. Next slide, please. All right, so here's a tip to make you faster. After you put your 12mm trocar in at the umbilicus, take a look. If it's one or both sides, put 1 or 2 pieces of mesh in right up front so it's in. I throw my sutures in. I put V-lock in and my Vicryl. Everything's in. Before I put my 12mm trocar in, I tend to score the fascia so that it'll fit through snugly but still fit through. So I preload that fascial defect with Vicryl UR6 figure of 8 so that when I go to the console, my mesh is in, my suture's in, I do the entire repair, we pull out a couple of needles at the end, then Mackenzie already has a fascial stitch in to close the fascia for me, and then she closes the skin, and I'm off dictating, consenting the next patient, so things move very quickly. So throw it all in the beginning and make yourself faster. It's a nice little tip. Again, when I break down, look at my results. Here's my results. Again, I do track myself. This number here is inaccurate. I did repaired 6 hernias, inguinal hernias today, so that should be 322 to be 324 as of tomorrow. These are my results. We track everybody. Recurrence rates out to a year is 0. Chronic pain, I had one gentleman with chronic pain at a year. He had chronic pain before the operation, which I was hoping would get better. It did not. It's all genital branch of genitofemoral nerve. I do have him on gabapentin, and he's about a 3 out of 10 and is reasonably happy and functional. 2 nerve injuries. One was this guy, although he really had the pain beforehand, but I'm counting that as a potential nerve injury. The other guy had some numbness in the groin at the femoral branch, the genitofemoral branch, over about a maybe 3 to 4 centimeter area that went away after about 3 months. So those are my 2 nerve issues. Seromas, 4.3% of seroma, very low. minimal blood loss always, and about 1.3% of my patients have to get a Foley in afterwards because they can't pee. Low number. I do not put a Foley in beforehand. I'm a pee before you go back person, and then you get a catheter if after we bladder scan you and you're about to explode and you can't go, then we'll drop a Foley and send you home with some Flomax and pop it out in the office in a couple days. Generally, though, this is usually old guys with big prostates. Pain scores. We track everyone on pain scores as well. And here's 1.82 at 2-week follow-up. That's the average score. A lot of zeros in there. A few 10s because I do operate on workman's comp guys, and those guys are always 10, even though they look just fine to me. But amazingly, their pain scores get better once they are back at work. So at 6 weeks, the drop stent just keeps getting smaller and smaller and smaller. And at 6 months, very, very low pain scores, which is why I see those studies showing, 16% and 28% long-term chronic pain. It's a sexually high number, and we're calling people and asking them, and those are our numbers. So very good success with the robotic tap. Again, we're skipping. We're not talking about ventral hernia. We're going to jump right to this slide here. I'd like to say thanks for your time and thanks for coming out on a Thursday night on the West Coast. I'm assuming it's more than just California. Here's a practical use. I'm a bow tie guy. So here's a practical use for the robot. We're going to get this bow tie tied nicely. It took me about 8 times to figure this out because I'm used to looking in a mirror and doing it with 2 hands. So this is a frontal assault using the robot. But able to get this done, I'm going to show you the critical move right here. Coming up. Wait for it. Wait for it. Here it comes. Boom. Right there. That's the critical move. And there you go. And this is what they call the critical view of the bow tie tying right there. Love the critical view. And there we go. All right. And that's it, guys and ladies. So if you guys have any questions, fire away. We're here for a little question and answer session. Bearing in mind, I may get a little slap at because it's 10 o'clock and I operated for like 17 hours on Tuesday and I still haven't recovered.
Thank you, Dr. Swope, for sharing your experiences. For everybody on the webinar, I would encourage you to type your